Thanks for the opportunity to present our work today. My name is Arturo Rios, and I'm a former research fellow at the University of Pennsylvania Division of Plastic Surgery. We have no disclosures. RHIS sensation is an unwanted outcome following ABR or autologous breast reconstruction. According to some studies, neurotization enhances the magnitude and rapidity of sensor restoration. However, there has been question in a recent meta-analysis in review literature that showed that there is significant methodological variability and inconsistent use of outcome measures, which does not allow to establish meaningful comparisons between studies. Furthermore, most studies have been retrospective in nature and with small sample size, leaving a need for more prospective trials with larger sample size. Therefore, we sought to compare the long-term breast sensation and patient-reported sensation outcomes following neurotized and non-neurotized ABR. We designed a prospective trial by a single surgeon, including women undergoing unilateral or bilateral ABR with a free flap that were 21 years old or greater, and that were at least 1 year post-op. The advanced allograft was used as a conduit for the neuroraphy between the sensory intercostal and medial intercostal nerves. Clinical data was extracted from the EMR. Sensation data was ascertained using the Acroval pressure-specified sensory device testing. And the testing included 1-point static and 1-point movement. Quality of life was extracted using the breast Q questionnaire, and we also included a sensation questionnaire for PROs. The following diagram shows a representation of all the areas that were measured for sensation using the Acroval device. This device provides a number or value between 0 and 100, with 0 representing the highest number for sensation and the lowest sensation being 100. The chart on the right shows the theoretical pressure at which sensation is normal, showing between 2.5 and 5.5. Anything greater than this is considered either diminished or loss of protective sensation. The statistical analysis were as listed. The following table shows all the characteristics between non-neurotized and neurotized patients. There were 93 patients undergoing 155 flaps. There were only differences in terms of race, obesity, and immediate reconstruction, with a greater proportion of immediate reconstruction than in neurotized groups. The following diagram shows the actual sensation results for the 1-point static test, showing increased sensation for the neurotized patient in the superior mastectomy flap and decreased sensation in the inferior mastectomy flap. No differences were observed in other areas or when comparing areas by the 1-point movement test. In terms of quality of life data, the breast Q domains were statistically significant difference between the two groups, where the physical well-being and the abdomen lowest scores in the neurotized group, and a higher satisfaction of the nipple areolar complex for those undergoing neurotization. The following table shows that there were no differences in patient-reported outcomes in terms of perceived sensation, numbness, tingling, paresthesia, or temperature perception. However, there was a larger proportion of patients that expressed that their daily life was affected by their sensation in the non-neurotized group compared to the neurotized group. In summary, this is a larger prospective sensation study in the United States for patients undergoing ABR. There are conflicting results in terms of sensation for both neurotized and non-neurotized groups. And the daily life seems to be affected due to sensation for more patients without neurotization. Both groups shows loss of protective sensation in all quadrants, which is important to highlight. We have to acknowledge that this is a non-randomized controlled trial, and therefore is subject to selection bias, and they were based on differences that we could not control for, and we're working on obtaining a larger sample size for statistical modeling. In conclusion, for the most part, there are no significant differences in sensation between neurotized and non-neurotized patients undergoing ABR. Further research is warranted to account for patient differences between the two groups and determine the true value of neurotization at the time of ABR. There is a loss of protective sensation regardless of neurotization, which speaks to the difficulty of achieving close to normal sensation restoration in ABR. Thank you.